Well, welcome everyone. I'm Casey Peluso from Parkinson Foundation, Western Pennsylvania, and Christine Haythorne, our Executive Director, and CEO of Parkinson Foundation, Western Pennsylvania, is also joining us today. And thank you for signing up and attending. This webinar will be recorded and it will be on our YouTube channel afterwards. And I'd like to welcome you to the Managing Moods, Coping with Depression and Anxiety in Parkinson's Disease webinar. And now I'd like to introduce you to our presenter today, Dr. Joyce K. Smith. Dr. Smith is a psychologist with over 42 years of experience. She has a Bachelor of Science degree from Allegheny College, a master's degree from Edinburgh University, and a doctorate of psychology degree from Indiana University of Pennsylvania. Dr. Smith has provided a multitude of services to children, adolescents, adults, and older adults for various mental health needs. She has worked in a wide array of settings, including community-based consultation for developmentally challenged adults, geriatric outreach to identify mental health needs and to minimize hospitalization, and forensic mental health counseling as well. She has also been a liaison with schools and has co-facilitated support groups for families of the severely mentally ill and survivors of suicide. She has also provided individual and group therapy, as well as in a partial hospitalization program, as well as individual and family therapy in community mental health and private practice for such issues as anxiety, depression, grief and loss, attention deficit hyperactivity disorder, relationship issues, and stress management. Dr. Smith has conducted psychological evaluations on an outpatient mental health unit, as well as for outpatient clients. These evaluations included pre-surgical evaluations for spinal implant and gastric bypass, evaluation for attention deficit hyperactivity disorder, and lethal weapons certification for local law enforcement officers. Dr. Smith has also trained in mediation and collaborative divorce work, with a focus on helping couples and families work through difficult times in a more positive, less emotionally damaging way. Dr. Smith recently retired from direct clinical services at Cranberry Psychological Center after serving for more than 17 years there. So we are really honored to have Dr. Smith presenting to us today. And before I hand it over to Dr. Smith, I just wanted to mention that there will be time for questions at the end, in which you can either unmute yourself and ask the question, or you can use the chat function. And lastly, if you think of a question during the presentation, you can submit that through the chat function, and then I'll ask Dr. Joyce those questions at the end. So without further ado, Dr. Joyce Smith.
Thank you, Casey. It's a pleasure to be here. I appreciate it. Good afternoon, everyone. I am a person who is much more comfortable talking individually to people than public speaking. And I am not very experienced with technology, but we'll do our best today. So I would appreciate any patience if we run into issues. So today I'll be talking about differences between normal moods like sadness and illnesses like depression, and also how that's different. So often when a person is diagnosed with a chronic illness, they respond with grief, and grief is different than depression. Additionally, anxiety or stress or distress have differences that can be identified. So I'll be presenting some information on strategies for coping with chronic illness, especially the emotional challenges, and additional strategies to use to cope with depression, or sometimes to help prevent depression and anxiety. So I plan to save 15 to 20 minutes at the end for any questions, but as Casey said, you can put your questions in the chat box, and then we will get to those. I'm going to switch to my slides now, and let's see how that will work. Okay, I think we did it. All right. And from the beginning. Okay. So here we are, managing depression. So depression, together around 40 million adults experience depression or anxiety in the United States sometime in their life. One other estimate is that 1 out of 5 people suffer from depression and 1 out of 4 people may experience an anxiety disorder. So together, depression and anxiety have the greatest impact in the health of people with Parkinson's disease, even more than movement challenges. Can people see the screens okay?
Yes.
Okay.
Did
All right.
everyone else?
All right, because my pictures are kind of in the middle of my screens, and I wasn't sure if that was a problem for other people. But okay, so if there's a problem, just let us know. So it's estimated that up to 50% of people with Parkinson's disease will experience some form of depression during their illness. And estimated that 30 to 40% of people will experience an anxiety disorder. So we'll begin by trying to identify what we mean by mood. So a mood is a temporary feeling, state of mind or a feeling, or it's an awareness of a conscious state of mind of a predominant emotion. And generally our moods change with, according to the situation we're in. So, for example, if you just scratched off your lottery ticket and found that you won $100, your mood might go from neutral to happy. Or if you hear that a family member is having a serious illness, that might change your mood from happy to sad or to worried. So our moods are impacted or influenced by situations or circumstances, but they're also biological influences. Our brains use chemical signals called neurotransmitters to communicate and regulate function. 3 neurotransmitters, dopamine, serotonin, and norepinephrine, are involved in regulating mood, energy, motivation, appetite, and sleep, among other things. Changes in the levels of these neurotransmitters can lead to mood disorders. Changing levels of any of one of these neurotransmitters can impact the levels of others. So Parkinson's disease is a chronic, as you know, a chronic degenerative condition in which dopamine cells slowly die. The loss of dopamine generating cells in the brain results in a complex array of symptoms, both motor and non-motor. So if we begin, we can talk about sadness. Sadness is a normal emotion, although we often hear people express their sadness by saying, I'm depressed. Most of the time what people are saying is they're feeling sad. The sadness can be associated with grief. It can be a symptom of what we call an adjustment disorder, which is an emotional response to some event or stressor in the 3 to 6 month period. Or it can be a symptom of a mood disorder, like major depressive disorder. Sometimes people call it clinical depression, or a different form of depression called dysthymic disorder. So understanding the differences will involve examining the context in which the emotion or symptom is present, how intense or severe the symptom is, and how long the symptoms last. Again, sadness is something that we frequently associate with grief or loss. And most people are familiar by now with these stages of loss that were identified by Elizabeth Kubler-Ross. Shock and denial, anger, bargaining or guilt, depression, and then finally acceptance. This is a time that the word depression is often used as a synonym for sadness. People can have both a grief reaction and clinical depression, but most of the time, the depression that people feel is really sadness. So everyone feels sad sometimes. It's a normal emotion, and generally, it's triggered by some event. And it might be something that's difficult or hurtful or challenging or disappointing. And when the situation is resolved, typically the sadness passes. For example, over the past week with the 20th anniversary of 9/11, as I was watching, television and seeing the events unfurling again and kind of thinking about it, I felt sad. When I would stop watching television and go about business, again, the sadness lifted a little bit. Whereas depression doesn't need a trigger, it doesn't need something that suggests you feel a certain way. It's more about how you feel. It affects how you think, how you perceive, and how you behave. Depression is an abnormal emotion, and it's a state that can have a negative impact on how you function in social situations. So how do we diagnose depression? So what we're looking for are the presence of 5 or more of the following symptoms that exist for more than a 2-week period and reflect a change in the person's functioning. So the kinds of symptoms would be feeling sad, guilty, or helpless, a sense of worthlessness, reduced sense of self-worth, a loss of interest in activities or loss of pleasure in previously enjoyed activities, digestive problems, changes in your gastrointestinal symptoms, can be some physical aches like headaches or backaches, just more discomfort, changes in weight or appetite, and this can be an increase or a decrease, changes in our sleep, and again, that can be not being able to sleep, like having insomnia, or sleeping excessively. Changes in concentration, and because we're having problems concentrating, we're having trouble focusing and and maybe making decisions. We often feel restless, pessimistic or negative thinking, irritability, things bother you that might not normally bother you. And in more severe cases, sometimes there is the presence of suicidal thoughts or a plan. So let's look at the differences between grief and depression. There are many shared characteristics. Sadness, fatigue, that low energy, problems with concentration and focusing, not being as interested in the outside world. People often feel anxious or worried, may have headaches or stomach upset or more pain. They may feel angry. People sometimes, especially when anxiety is stronger, worry that, they're losing their mind because they may be more forgetful about things. Some people will struggle with spiritual estrangement or changes in their relationships with family or friends. And everyone wants to feel better, wants the pain to end. With grief, the mood tends to be a little more variable. It's not sadness all the time. It shifts during the day from sadness to anger, kind of more neutral moods. The person is focused on the loss of the loved one or the loss that they're feeling the grief about. With a chronic illness, it could be focused on the loss of their health. Generally, people during grief respond to the warmth and reassurance from other people. when someone sits with you and, is comforting or offering a hug, you tend to feel better. And not better, but you feel a little relief, or you feel the comfort, and tend to stay connected with family and friends. With depression, the mood is a little more persistent. So person might feel immobilized or stuck. A typical symptom of depression is social withdrawal. Person may feel hopeless or despondent. One symptom that exists with depression and kind of feeling an overwhelming sense of guilt. Again, thinking more negatively about themselves. And, even if someone gives them a hug or they know someone is really caring about them, that doesn't change the deep down feeling that they have of the depression. And sometimes then they'll lose that connection with other people. Again, so it is possible that people do develop depression with grief, but grief is typically a different process, a separate process. Depression in the course of Parkinson's disease may be experienced at any time, even before the diagnosis. It's thought that the resulting changes in the chemistry of the brain may lead to diagnosis of depression even before some of the movement issues are identified, and people then make a diagnosis of Parkinson's disease. One of the things that can be different with depression for an individual with Parkinson's disease is the depressive moods might be more intermittent, meaning there may be smaller or shorter episodes of depression. So the mood is more depressed and then it begins to improve, but then the depression, reoccurs. And that's whereas with individuals without Parkinson's disease, sometimes it's more persistent. So you may see kind of an up and down in the ways of dealing with depression. One other thing that I had come across when I was doing some research was it's most common for individuals with Parkinson's disease to not have that experiences of excessive guilt that might be present in some other people who have depression. So depression can intensify both motor and cognitive symptoms. And it's important to treat the depression because that can improve the quality of life and movement. So if we've talked, depression can have many causes: psychological, biological, but also environmental. Psychological factors can include negative thoughts about attitude, negative thoughts and negative attitude about living with a chronic illness can lead to feelings of sadness, helplessness, and hopelessness. Dwelling on these thoughts may tend to make the person more vulnerable to depression or anxiety, which we'll talk about in a few minutes. Social isolation or a lack of a support network can also contribute to increased risk for depression. So some examples may be if you're at work, so you may be more vulnerable to depression, or if becoming less independent may also make depression more likely. We talked briefly about the changes in the brain. These are some biological factors that Parkinson's disease and depression affect the physical parts of the brain involved in thinking, and that these levels of the important neurotransmitters, dopamine, serotonin, norepinephrine, are involved in influencing mood and movement. Research suggests that people with Parkinson's disease may experience depression or anxiety 2 to 5 years before the diagnosis of Parkinson's disease. And so then it suggests that depression is really a part of the illness and not a reaction to the illness. And environmental factors may also be a part in making people more vulnerable to depression. So severe stress can lead to being a little more vulnerable. And, so obviously one kind of severe stress might be ongoing distress about coping with this chronic illness. Side effects from certain medications may also make a person more vulnerable to developing depression. As we mentioned, suicidal thoughts might be associated with depression. When asked, up to 30% of people with Parkinson's have admitted to having some thoughts about suicide. Risk factors include undiagnosed or untreated depression, social isolation, feeling helpless or hopeless, or experiencing severe anxiety that's untreated. One of the bits of information I discovered was although there may be higher rates of suicidal thoughts, in general, there are lower rates of suicide attempts in individuals with Parkinson's. But if you do have thoughts of suicide, it's important to utilize the resources that are out there. For example, the National Suicide Helpline, National Suicide Prevention Lifeline, their number is 1-800-273-8255. And that's if you're having thoughts, but if you think the risk is imminent, to call 911. Obviously, you want to seek professional help, and that can start with your primary care doctor, your neurologist, or meeting with a therapist. Getting involved with a support group is something that's important, and staying engaged in activities. You want to prioritize self-care and building in relaxing and enjoyable activities and making sure you're getting adequate sleep. Again, that number for the National Suicide Prevention Lifeline is 1-800-273-8255. So we talked a little bit about anxiety and how that can play its role. And people may experience anxiety on its own or as a part of or in conjunction with depression. We use a lot of words. With depression, we typically use the word sadness, but we use a lot of different words to describe anxiety. We might say nervous or tense or jittery or worried or stressed. And stressed is one of those words that we do tend to use as kind of a synonym for anxiety. But stress is a little bit different. Again, it is a feeling of emotional or physical tension. It can lead to, a body's response to, and that can have an impact on chemical changes with blood pressure, with your heart, blood sugar levels, or leading to feelings of frustration, anger, or depression or anxiety. People think about stress kind of you're moving into a new home, or you find out your child is getting married, or you just won $1 million on a lottery ticket. There is stress associated with that, but it's good stress. What we refer to as bad stress is distress. So distress is when pain or suffering affects your body, a bodily part, or your mind. Distress is more likely to be experienced when stress is chronic, or there are many unknown or unfamiliar aspects involved, when there is a lack of sense of control and the person feels alone in that situation. So I mentioned that I, I'm much more comfortable talking individually with people. So I felt stressed and some distress in preparing for this. But the difference is with stress and anxiety. So stress is a reaction to external factors, me preparing this presentation. And sometimes it can lead to feeling overwhelmed, but the stress resolves after the stressful event is over. So, as the day goes on, I will be feeling less stressed. Whereas anxiety is a reaction to internal factors, where we're feeling this intense worry or fear. And these feelings hang on long after any kind of a stressful thought or event occurs. So while anxiety is an emotion, it can be associated with grief. It can also be a symptom of an adjustment disorder, and that's that reaction to an event up to like 6 months after with an anxious mood, or it can be a symptom of an anxiety disorder. These are some common symptoms of anxiety: feeling nervous, restless, or tense, feeling this sense of impending doom or danger or panic. People often describe an increased heart rate, an increase in sweating or clammy hands. People will feel weak or fatigued or lethargic. They may tremble, which is different than tremor. They may have some gastrointestinal problems. I think we've probably all had experiences where we were anxious or worried, and we ended up spending more time in the bathroom. And then obviously there's those worried thoughts. So the thoughts of the negative things. Generally, we talk about a few kinds of anxiety disorders. Generalized anxiety is excessive anxiety and worry occurring more days than not for at least 6 months. And you're worrying about all kinds of different things. And the person finds it difficult to control that worrying. And most importantly, the anxiety or the worry causes significant distress and impairment in social or occupational or other important areas of functioning. Panic disorder involves recurrent panic or anxiety attacks. People use those words, panic and anxiety attack, pretty interchangeably. But a panic attack is a period of time where you have this increased fear or discomfort. It's often accompanied by an increased heart rate, kind of changes in your breathing. You feel like, some people say they feel like they can't breathe. Some people feel like they're choking. Some people may feel chest pain and feel like worried that they're having a heart attack. People might feel dizzy. Often during a panic attack, people feel like they're going crazy. So the panic disorder is something that we diagnose if there are recurrent panic attacks and at least one of the following: a persistent concern about having additional attacks, or worry about what the attacks mean, that they're going crazy, or that they're about to have a heart attack. But again, those are typically things that happen. They begin to be the worry after the attack has happened. Social anxiety disorder, which I've seen referenced in some materials as social avoidance anxiety, but it's a fear of being in a social or performance situation in which the person feels exposed and to some unfamiliar people, and maybe feels worried that people are going to be looking at them or watching them. So the person will often feel afraid that they're going to act in a way that will be embarrassing or humiliating. Often people will recognize that this is unrealistic, that people aren't really going to be only staring at them, but it feels that way in the moment. And this fear of being in these situations will often lead to people avoiding them. So, and so with this, again, we want the symptoms will need to exist more than for 6 months. Obsessive compulsive disorder is one that I think often people are more familiar with. People talk about being OCD, um, but basically it's persistent and unwelcome thoughts or images, and an urgent need to try to control them by engaging in certain rituals. I think one thing that might be something people are familiar with, or people have germ phobias or fears about germs, so they engage in excessive hand washing. Or they just can't stop worrying about things. So they feel perhaps they need to do something that helps to control the worrying. And then post-traumatic stress disorder is, an anxiety disorder that develops after an experience of a significant trauma. It's very understandable that people have a reaction, an anxious reaction, when they first receive a diagnosis of a serious illness like Parkinson's disease. But when the worrying or nervousness becomes constant, that's when a person may begin to develop an anxiety disorder. And as with depression, anxiety can be diagnosed even prior to a diagnosis of Parkinson's disease. And as I said, anxiety might present on its own or in conjunction with depression. Like depression, if it's not treated, it can worsen the person's overall functioning. There are some common fears and worries that go along with Parkinson's disease that can trigger anxiety. And as I understand during the research, that one of the times where anxiety may be more specifically heightened is during an off period when medications aren't working as well. And they can also then worry about, are they going to be able to function independently in the future? And that becomes the constant worry. So the diagnosis in Parkinson's disease, the diagnosis of anxiety disorder is made when the symptoms are a change from the person's previous behavior and not confused with motor symptoms. For example, there's maybe a legitimate concern that a tremor or change in walking would be noticeable in public. The diagnosis of social anxiety or social avoidance is only made if the person's aware that, their fear or their worry is excessive. They begin to avoid those social situations, and it begins to interfere with functioning in life. So those are some of the symptoms that we can look at. A little bit of a brief introduction to anxiety and depression. It's a lot of information to cover in a brief time. But I also wanted to be able to focus on things that you can do that can be helpful, that all of us can do. But when we have a chronic illness, we need to learn to manage the illness and our symptoms, manage our daily activities, and manage our emotions. So you want to become an active partner in your own healthcare. So you'll be kind of gathering information so you can prepare for medical appointments, finding the community resources, engaging with support that's available, and allowing family and friends to provide support. You want to maintain good physical conditioning. Becoming deconditioned can have an impact on your emotional state as well as your physical state. You want to try to maintain the activities you used to enjoy, or if you can't do some of those, find some new ones that you'd like to try. So living well with chronic illness means learning new skills to manage negative emotions. And we'll talk about this further. It's not that you want to avoid your emotions. You want to kind of explore them. Don't try to deny them, but expressing your feelings is very important. Unvoiced sadness or anger can actually undermine actions you can take to manage your illness. Be aware of your self-talk. What are you saying to and about yourself? And don't do it alone. Connecting with other people helps you to feel less isolated. Social support is very important. It's one of those factors that can help prevent depression as well as help improve your symptoms if you have developed depression or anxiety. So I wanted to talk briefly about some some strategies that you can use to help maybe prevent the development of some of these symptoms, as well as um, um, use it for treatment if the symptoms develop. So relaxation techniques involve refocusing your attention on something that's calming and allows you to increase kind of sense of control of your body. So there are both body techniques and mind techniques. The body techniques can include things like physical exercise, and that's either working with weights or walking on the treadmill, going for walks, or doing yoga, chair yoga, or Tai Chi. Deep breathing, which helps you to kind of lower your heart rate and feel more relaxed. Receiving a massage, or using some aromatherapy. Um, you know, having scented candles or other a diffuser with other scents that help you to feel a little more relaxed. There are also techniques of the mind. One is probably the most common one would be meditation. And one form of meditation that we'll talk about is mindfulness. There are different kinds of relaxation strategies, the use of visualization, progressive muscle relaxation, or something called autogenic relaxation. Humor is a very important relaxation technique. So making sure you have time to laugh with friends or family, or watching a favorite sitcom or a favorite funny movie that you like to watch. Music or art. So listening to some of your favorite music, or doing arts or crafts or woodworking. Again, it's about trying to refocus your mind onto something a little more relaxing and calming, or the use of cognitive behavioral techniques. Exercise has been shown to improve many of the non-motor symptoms of Parkinson's disease, can help maintain the ability to fight the progress, and staying healthy can reduce setbacks. Right? As I mentioned, it can involve all kinds of things: walking, stretching, Tai Chi, and all forms of basic activity like gardening, other things that you enjoy. Research has shown in general that with mild depression, exercise can be as effective as medications. Mindfulness is a group of techniques that allow a person to focus inward and kind of move away from the stresses that are outside. And you focus on awareness of your feelings, your thoughts, your bodily sensations, and can decrease stress and increase healthy behaviors. One example of a mindfulness technique is one in which you engage your five senses. So see in this picture, it's like, sitting in a chair, having a warm cup of tea, so you're going to feel that warmth in your body while you're watching the sunset outdoors, while you're listening to your favorite music. Maybe you have some cut flowers in the background that you can smell, or I have a candle going. You can savor your favorite treat where you're really focusing on that sweetness or that texture if you're chewing, or the texture is taste on your tongue. And of course, whether petting a family dog or cat, or if you don't have a pet, to be able to to give a person a hug, but something else that engages that sense of touch. So I think we're getting a little short on time here. So I will talk very quickly about um, some of the different relaxation processes. Um, so many of them will involve using your visual imagery as well as some physical technique. So with autogenic relaxation, it's basically focusing on calming your breathing while, um, you know, saying something that imagine yourself in a peaceful setting, or using the word when you're exhale, saying calm, um, as a way of just kind of talking yourself into feeling more relaxed. Progressive muscle relaxation is something that people may be familiar with, where you're alternately tensing and then relaxing muscles. This helps you to learn the difference between tension and relaxation. We often carry tension in our jaw or in our neck and shoulders. And so once you practice this, you develop a way of identifying that, and you can actually make those muscles relax. You alternate tensing. You can start at your feet, or you can start at your head. But tense those muscle groups for 5 seconds and then relax 20. While you leave those muscle groups relaxed, then go to the next muscle group. As I mentioned, some of the other techniques involve this visualization, where you take mental image, like to a peaceful, calming place, and try to incorporate as many of your senses as possible. This one is one of my favorites, and I use it at night when I can't sleep because my mind doesn't want to shut off. So I'll take myself to the beach. So, as I'm trying to focus on my breathing, I'm also becoming aware of the smell of the salt air, hearing the waves crashing against the shore, feeling the warmth of the sand on the soles of my feet, or the warmth of the sun on my face, and then visually just watching the rhythm of the waves kind of coming and going. And that's very helpful, sometimes in just being able to let go of the worried thoughts or depressed thoughts and focus on something that's more positive. So those are strategies that can be used for any of us at any time, just to focus on kind of being healthier and coping better. So two strategies for dealing with depression and anxiety may be psychotherapy or counseling. And the two most common ones that we think about are cognitive behavioral therapy or supportive therapy. Through the years, I can tell you lots of people have come in to see me and they say, I don't know why I'm here talking about this isn't going to make this any better. But really, it offers an opportunity to kind of vent your frustrations and share your feelings, get some validation of your feelings, receive some support and education sometimes. And this can be individual, as a couple or family, or in a group. Cognitive behavioral therapy involves changing your negative thinking patterns to reduce the symptoms of depression and anxiety. And it's learning skills to help think in a more positive way. These are skills and it takes practice. So it's not something that you just kind of think, okay, I'm going to think differently, but you can begin to practice some different ways. So CBT promotes problem solving and cognitive restructuring. I liked this little sign that I came across. You can't live a positive life with a negative mind. And certainly attitudes can't cure chronic illnesses or other serious things that are events that happen in our life, but positive attitudes and certain self-management skills can make it easier to live with those kinds of things. You want to try to begin to change your thinking, start to pay attention to what your thinking is. If you start to find yourself thinking something negative, write it down, and then think of ways to challenge it. You can write out a positive thought that challenges it. Or you can ask yourself, well, what's the evidence for this thought or this belief? Kind of saying it out loud helps you to think about it in a different way, or share it with other people. You want to try to avoid catastrophizing, that worst case scenario thinking. Another strategy comes from a different theory called dialectical behavior therapy, and that's developing distress tolerance skills. One of those skills is something called radical acceptance, and it's just a healthier way to think about things that are out of your control. So instead of focusing and thinking about and putting your energy into something you'd like to be different, you kind of recognize the problem and then you accept it. This is not giving into it or liking it. It's just thinking and energy in ways that are more productive, that will help you to feel less anxious, angry, or sad. Then, of course, dealing with some of the biological components of anxiety and depression, if a more moderate to severe depression or anxiety develop, then medications can be helpful. Antidepressant medications, I think are kind of more known in general. People are aware of different forms of medications. The medications can certainly help reduce symptoms, but are best used in conjunction with therapy. That research has shown that the combination of medication and therapy has a 25% better result than medication alone. Some people don't tolerate the medicine or don't wish to take the medicine, but also some of these medications may interact with medications for Parkinson's disease, and so they may not be something that other people or that some people are able to take advantage of. Now, I'm sorry, I think I ran a little bit over, but I did still want to open it up if there were any questions. If I could, further give some more details about things that I may have just glanced over. So we now.
Thank you, Dr. Smith. And yes, if you have a question, you can either enter it in the chat box or you can unmute and ask it verbally.
Please just call me Joyce.
Okay, Joyce.
I know I threw a lot of information out there.
I was told 12 or 15 years ago by a headache specialist neurologist that who treated me for migraine, that the migraine brain is more apt to depression, and that coupled with the Parkinson's is, I am on medication and do therapy. One of the things I would say is that I had very low sodium levels with all of the Prozac family of antidepressants, and had to be put on a very low dosage of lamotrigine, which is normally a seizure medication in high doses. And my level is back up again, almost to normal.
Good. Yeah, the lamotrigine is also used psychiatrically as a mood stabilizer. So it can help kind of stabilize a kind of a very depressed mood. So it helps to lift the mood a bit.
I guess my question there was, have you dealt with people who had migraine and PD?
I have not personally done that, but it makes sense to me that because the brain is complex but also interrelated, when one part of the brain is impacted by something like migraines, that can have an influence on other parts of the brain. And again, as I said, it may be that's a symptom even that precedes the diagnosis of Parkinson's disease.
I have a question. Steve Saxa. I had visual migraines when I was young, I don't, I occasionally have them now, but I just thought about that. But I'm doing physical therapy. I'm doing a lot of the items. I do as much as I possibly can do in various things. But I also take a CBD oil. I'm wondering if you have any comment about the CBD oil.
That is not something that I've read much research about. I know there's not much anxiety, but I know some people, there's no established research about that yet.
One of the effects is it brings me to the now, so I can concentrate on now, and I don't worry about. It's not a lot, but it gets me to the present. I'm not concerned about the future and not worried about the past as much.
So it sounds like that's helpful for you.
Thank you.
I have a quick question. I am a caregiver for my dad who has Parkinson's. And when we go into a doctor's office and they always have those questionnaires, he always marks that he has anxiety, but he doesn't ever say he's anxious. He doesn't have a lot of the symptoms that you talked about. So how can I help? What's the best way to help him, figure out what he's anxious about? Do you have any suggestions? Like, obviously I've talked to him, but are there anything I should look for?
You really hear that? Could you repeat your question, please?
Locking up.
Casey, I don't know, are you able to hear that better? Is it on my end that there was a problem with the internet?
It might have been. I believe Elaine was asking, is there something that she can use to kind of assess her dad's anxiety and perhaps take it to the doctors with her?
I don't know of specific forms, but like most things on the internet, you can go in and look for a list of anxiety symptoms. So I'm sure you would probably be able to find something that you would be able to use to describe it, and could kind of say, as we talked about, it's about the severity of the symptoms. We're all feeling a little anxious sometimes, but if it feels like you're feeling this chronic tension and it's so severe, you're feeling discomfort. So you want to talk about that, or how persistent the symptoms are, or how often he's feeling that way. But I think if you can probably find a checklist online, I don't have one. I could look for one and try to send that out to Casey, but I don't have one right now.
Is your dad involved with a support group?
Yes, he is. We go once a month.
Does he do exercise?
Yes. Which is why I was surprised when we fill out the forms and he says he's anxious.
I think men have a more tendency to not devote explain weakness, because women talk more openly than men. Men kind of say, "I'll get through it," and I'm weak if I show I'm a weakness, or anyway. You understand what I'm saying?
Yes, thank you.
Yeah. And often people do suffer more internally, and it's not always easy to know if somebody's feeling anxious or depressed. And so that's why sometimes you do have to ask those questions or find checklists. I think that's why they're doing more screenings in general in PCP's offices these days. to try to identify that.
Thank you, Joyce. We have a question in the chat box.
Okay.
Have you heard of a company called Gene Site? I'm told they do a pharmacogenomic testing, determine how a person's genetic makeup may make different medications more suitable over others.
I have heard of it. I don't know a lot of details about it. It is something that someone I had worked with who had a lot of bad reactions to some of the medications. She did have the gene workup, the genetic workup done, and they were able to identify what medications might be better for her and why she had the reaction she had to the medicines in the past. So I think that that's probably something that I would think psychiatrists would be aware of. I'm not sure if that's something that primary care doctors are aware of, those kinds of resources. The medications involve kind of more art than science sometimes because people do have individual responses to them. So that's why if you've really had some trouble with the medicines, something like this testing may be more beneficial.
Thank you. We have time for one more question if there's any other questions out there. Okay. Well, thank you so much, Joyce,
Oh, you're welcome.
for such a thorough presentation on anxiety and depression with grief sprinkled in there. And I think it was really helpful to learn of some techniques as well.
Thank you very much. Sorry I ran short and we breezed through those techniques at the end, but you know, I think they're helpful for all of us to be able to utilize.
Absolutely.
Thank you very much.
Okay, have a great afternoon, everyone. Bye.
Bye-bye.